This video is an introduction to diabetes and ocular pathophysiology. Some of the ocular side effects of hyperglycemia are cataracts, diabetes-related retinopathy, and macular edema. The ciliary body produces a fluid that circulates around the crystalline lens. When excess glucose and advanced glycation end products are present, reactions within the lens causes an opacity, which forms a cataract. Cataracts cause vision loss by allowing less light to enter the eye. Looking at a cross-section of the retina, the retinal neurons, the retinal vessels, and the interconnecting cells, referred to as retinal glia, compose the neurovascular unit. The neurovascular unit is used to illustrate how diabetes causes diabetes-related retinopathy. If we enlarge the neovascular unit, we can identify its various parts. The retinal vessel is composed of the endothelial cell, the basement membrane, and the pericyte. The astrocyte cell and remaining glia that are not pictured in this slide connect to the retinal neuron. Hyperglycemia initiates various pathways that include formation of advanced glycation end products, reactive oxygen species, oxidative stress, and inflammation that affect the functioning of the neurovascular unit. Diabetes-related retinopathy can occur in the retina, the macula, and the fovea. Prolonged hyperglycemia over time overwhelms the neovascular unit's ability to function normally. The retinal capillaries begin to bulge and hemorrhage small amounts of blood. This condition is referred to as nonproliferative retinopathy. The various clinical signs of nonproliferative retinopathy include cotton wool, macular aneurysms, dot, blot, and flame-shaped hemorrhages, venous beading, hard exudates, and edema, a precursor to proliferative retinopathy. If the hyperglycemia continues, the retina becomes more hypoxic, and in response new vessels are formed in an attempt to correct the condition. Neovascularization marks the beginning of proliferative retinopathy. Unfortunately, the new vessels are fragile and subject to rupture, referred to as a retinal or a vitreous hemorrhage. As time progresses, a retinal adhesion can form and possibly cause a retinal detachment. Swelling from fluid accumulation in the macula and fovea is called macular edema. This condition can occur at the same time as nonproliferative or proliferative retinopathy. It is considered retinopathy, but because it has such a severe effect on vision, has its own separate category. Hypertension may also contribute to diabetes-related retinopathy. Inflammation, activation of the renin-angiotensin-aldosterone system, and hemorrhage or leakage from increased pressure damage to the retinal vessels increases the stress on the neurovascular unit. Exposure to large amounts of solar radiation may potentially be an increased risk factor for a person with diabetes. UVA and UVB radiation, commonly called blue light, are absorbed by the retina and the lens respectively. If the exposure is of sufficient intensity and duration, it can potentially cause advanced glycation end products, inflammation, and reactive oxygen species. What does diabetes-related retinopathy look like clinically? The first two images are of nonproliferative retinopathy. The first image shows dot, blot, and flame-shaped hemorrhages. The white wispy area is called cotton wool. The following image shows a larger hemorrhage and hard exudates. Hard exudates are the remnants of edema and leakage from a retinal vessel. The third image shows a presumed macular edema. The hard exudates are a clinical sign of prior and possibly current edema. It can be assumed that this person has lost some of their central vision. The last three slides show different stages of proliferative retinopathy. The first image shows newly formed vessels referred to as neovascularization. The next shows a vitreous hemorrhage resulting from a neovascular rupture, and the last image shows retinal vitreous adhesions. Thank you.